Dear all, on behalf of the Indian Society of Hematology and Blood Transfusion, I welcome all for the 21st Masterclass lecture on platelet function disorder, clinical profile and diagnostic approach. Without no wasting further time, now I welcome teacher for today's evening event, Dr. Jasmita Das, Assistant Professor, Department of Hematology, All India Institute of Medical Sciences, New Delhi. Over to you, ma'am.
So we'll start with the 21st masterclass. The topic is platelet function disorders, clinical profile and the diagnostic approach. So this will be the outline of the talk today. So basically I'll take you through two cases and we'll discuss how the testing has to be done. So what do we understand when we're talking about platelet function disorders? So either the function is the only problem, which is effectively the thrombocytopathy, or even the numbers are reduced, which is thrombocytopenia, and many of these disorders, they are inherited as well. Or there can be disorders which have a combination of both, that is both inherited thrombocytopenia as well as an inherited disorder of platelet function. And there is a diverse list of these disorders. Why is the list diverse? Because there are over 2,500 platelet proteins, and these disorders, they have a complex and heterogeneous pathogenesis. There is no single diagnostic test. And for lab investigations which have been available forever, even for those investigations, standardization process is still underway. In addition, there is an increasing use of high throughput sequencing for the diagnosis of platelet disorders, and this high throughput sequencing has also enabled the addition of new numbers to the entity. So when we talk about prevalence of platelet function disorders, it has not been examined in population-based studies, but among the patients evaluated for a bleeding disorder, the prevalence for dense granule disease is estimated to be similar to von Willebrand's disease. And the reason for this is that you have mild aggregation abnormalities with ADP or epinephrine, and which are fairly common. However, using the gene sequencing tool, a prevalence of about 0.3 to 9% was shown when a 58 gene panel was applied. So this is an overview of the number of genes that are involved for early megakaryopoiesis as well as for platelet activation, signaling, and platelet aggregation. And therefore, we can understand the sheer number of disorders which can affect platelet numbers or which can affect platelet function. And for the lecture today, we primarily concentrated on the inherited disorders and not the acquired ones. So when we talk about inherited thrombocytopenia syndromes, and here I've listed only those conditions which are associated with the bleeding diathesis as well. So these are the autosomal dominant disorders, and they range from ETV6-related thrombocytopenia and leukemia predisposition to Noonan syndrome to a classical cubic platelet disorder. And there are new genes and new disorders which are continuously being added to the list. For the autosomal recessive disorders, again, there is a list of disorders, including BSS, which we traditionally know of as a platelet function defect. But this is a defect which is a combination of both thrombocytopenia as well as a defect in the platelet function. In addition to that, we have other defects like ARPC1B deficiency, in which eosinophilia is associated along with the defect in the platelet function. X-linked disorders are few, and these are FLNA-related thrombocytopenia and GATA1 related X-linked thrombocytopenia. And the interesting part is that this has erythropoietic anemia as well as thalassemia like peripheral blood findings. So next, we come on to the list of inherited platelet function disorders, for which for most of these, the platelet counts actually are normal. So if we have a look at these disorders, Glanzmann thrombocythemia is the classical one that we always read about when we talk about hereditary platelet disorders. And the mutations are in the ITGA2B and ITG3 genes. This is a recessive inheritance, and the mutation has to be present on either one of the genes, both the mutations. So if one allele of ITGA2B is mutated, one allele of ITGB3 is mutated, it is not Glanzmann. It is Glanzmann only when it affects one gene, both alleles. The other disorders here are LAD type 3, and this is the gene is POMT3, it codes for the kindlin protein. Interestingly, it gives defects like GD. So the classical defects that we remember are absent aggregation responsive to all organoids. In addition, again, we have a disorder here which is very interesting, which is the Scott syndrome. It is encoded by the gene ANO6. It is a defect in the scramblase. So the procoagulant activity, which is determined by the phosphatidylserine and ethanol being exposed on the inner leaflet, that does not happen in this scenario. Now the list continues, and here you've got further disorders in which we have the RAS GRP2 related disease. Again, aggregation defect resembles Glanzmann thrombocythemia. In addition to that, we have the P2Y12 release defect, which has reversible ADP aggregation even at high ADP concentrations. In addition to that, in all these lists, we realize that there are some disorders which are associated with other features as well. And so, for example, if a patient is coming with oculocutaneous albinism or pulmonary fibrosis, and we have gray platelets on the peripheral blood, then we are possibly looking at a monthly food blood syndrome. So we have these two case scenarios. One is of a 4-year-old boy with recurrent epistaxis 4 to 5 times per month for the last 2 years. He's required packing and cauterization. ENT evaluation was normal. In addition, he reports having some black colored stool episodes twice in his life. The next is a 13-year-old girl who's been referred to us for severe menopause and ecchymotic patches on the lower limbs. Her family history is quite significant because there is history of easy bruisability in the father and the paternal grandmother. Father bled after tooth extraction and has anemia, was diagnosed as MD. So overall, this feature appears like there is an autosomal dominant disorder because it has been there in multiple generations of the family and it is not skipping generations. Okay. The interesting history is diagnosis of MDS. So what is the clinical profile of platelet function disorders? So platelet function disorders, unlike the classic clotting factor deficiencies like hemophilia A and B, the deep tissue joint bleeding is rare. Interestingly have the mucocutaneous type of bleeding. That means that the skin bleeds, epistaxis, oral cavity, GI or genitourinary bleeds will be very common. So ecchymosis, petechiae, they are manifestations of skin bleeds. They will give a history of prolonged bleeding after minor cuts and wounds. Deep tissue bleeds will be uncommon, and bleeding with invasive procedure usually starts immediately rather than the delayed part that we see with clotting factor defects. With respect to manifestations other than bleeding, we've just seen that there can be other manifestations dependent on which type of platelet function disorder we're dealing with. And if we have these manifestations, then they can guide us testing for or expected diagnosis of the inherited platelet function disorder. So if we try to find which clinical manifestations give a good odds ratio, so for excessive bruising in females, again, there is a good odds ratio. In addition to that, any patient who's required a transfusion obviously has had a severe bleed. If you have minor wounds which bleed for over an hour, if it's access that lasts over 15 minutes, for example, these are all events which are associated with high odds ratio for having a definite bleeding disorder. Now, coming on to the bleeding assessment tools. So why do we need bleeding assessment tools? So for the bleeding assessment tools, they assess if bleeding is significant or not. And these tools, they've got a high negative predictive value in screening patients with a bleeding disorder. So these investigations, they are multiple and they are not available at all the centers. So this batch scores, they become a tool to rationalize intense laboratory investigations. And they are also a short form approach to communicate between healthcare providers that what is actually the bleeding severity. So higher the batch score, we know that the patient's bleeding severity is higher. So as per these guidelines, this guideline given by 4 organizations which work collaboratively, in a low probability setting like a primary care setting, a BAT is recommended before you start screening the patient further. In the intermediate probability setting, when a patient has been referred for hemat evaluation, either based on the history or the APTT, for example, then BAT will not decide the testing, but still it is good to assess and document the severity of patient. Similarly, in a high probability setting where the patient has been referred with symptomatic first degree relative who's been diagnosed with a disease, BAT will again not guide testing, but will assess and document the severity of bleeding. And this is typically the guideline covers von Willebrand's disease, but the same factors will also apply for platelet function disorders. So when we talk about evolution of the bleeding assessment tools, it has been a wide progression, and finally the ISTH BAT score was given in 2010. It is a score which uses 14 different types of bleeding and grades them from 0 to 4. And the scores are calculated after ticking what the patient has. So understand that here, they've tried to make it objective. So epistaxis, you have to count the number of episodes or the amount of time that it lasts for, and the interventions again have to be noted down. So the same thing has been done for epistaxis, for minor wound bleeding, for cutaneous bleeds, even for menorrhagia. So all this assessment is done, and a total score of 0 to 56 is possible, but a significant score is considered when a child has a score of 3 or more, an adult male with a score of 4 or more, or an adult female with a score of 6 or more. So this pictorial bleeding assessment chart is also recommended for grading menorrhagia. And if we can do it for our patients, then that is good, because menorrhagia is a symptom which is not very easily quantifiable. What I may feel as increased bleeding, some other female may perceive it as completely normal. So for inherited platelet function disorders, an ISTH VAT of 6 has a 99% probability of having an inherited platelet function disorder after we have excluded von Willebrand disease. And again, there is a high negative predictive value of ISTH VAT. So for a severe platelet function disorder. So for a severe platelet function disorder, it does have a high negative predictive value, but it means also that if there is a mild inherited platelet function disorder, the VAT score may not be truly reflective of it. So the challenge is that, as I said, with mild bleeding, it may not reach the threshold for positivity. Also, a correlation with family history clinical presentation is required, especially when there are extra hematological manifestations, which are not really covered by. Also, understand that BAT is difficult to administer to children because they may not have faced enough hemostatic challenges. Let us come back to our cases and see whether they do require any workup for a platelet function disorder or not. So for this 4-year-old boy, he's had epistaxis 4 to 5 times, which has required packing and cauterization, which makes it a score of 3. For black-colored stools, incidental episodes, a score of 1. So his ISTS VAT is 4. He does require further evaluation. And for the 13-year-old girl who was referred for severe menorrhagia, which has required, now we asked the history, so it turns out that she has required a blood transfusion and has ecchymotic patches which are over 1 to 5 centimeter size. So that is a score of 2. So she comes on to a score of 6. And as I had discussed earlier, the family history suggests an autosomal dominant pattern. So what is the next step in evaluation? The next step is doing a screening quadriogram, and which is something which we do for all our patients who come to us with a suspected bleeding disorder. So this will include the PT, ABDT, TT, fibrinogen, and a CBC is a very important part because it tells you not just the platelet count, but a smear evaluation also tells you the platelet morphology. It tells you the morphology of other cells, and it also tells you whether the patient has anemia or not. So if a patient is bleeding severely, they can be anemic, and that can again be a sign that you pick up on the CBC. With respect to more screening tests, we can do the PT, the bleeding time or the PFA 100 if we have it, and we also have to rule out von Willebrand disease. So these are the tests which we do for evaluation. So bleeding time is a test that basically tests the primary hemostasis, the testing for platelet plug formation and capillary integrity. So it is dependent on the VWF antigen, the capillary function, the platelet count, as well as the platelet function, which means not just the count, but the part that these platelets are able to adhere or are able to adhere and then aggregate on. So an abnormal bleeding time can happen in all these situations. When you have thrombocytopenia less than 50,000, when you have platelet dysfunction, when you have severe von Willebrand or at least moderate von Willebrand disease, or when you have disorders of the vessel, which means it is not a specific test for only platelet function disorder. Traditionally, the IV method is used where you have a sphygmomanometer cuff, you inflate it to 40 millimeters on the upper arm, and then you do a cut on the forearm, 3 centimeter from the antecubital crease parallel to it on the volar surface, and you use a lancet or a simplate device, and you make 3 wounds. Why do we make 3 wounds? To ensure that at least one of them is a standard wound. And after making the third incision, you will start with the stopwatch, and you will only blot from the sides with the filter paper. You will not touch the wound. Maximum time that you measure it for is 15 minutes. So this is an example, and you have the sphygmomanometer cuff, and you have this device with which the cuts are made, and you have to observe for stoppage of the blood. The reference range is 2 to 8 minutes. Now, this is a test which is good for a severe inherited platelet function disorder. For example, for a case like GT, it will pick up 100% of the cases. For BSS, about 85%. The platelet secretion, about 68%. But it fares poorly in mild platelet disorders as well as in von Willebrand disease, the type 1 and the type 2 specifically. Type 3 is very well picked up by a bleeding time. So if you don't have anything else to assess for platelet dysfunction at your place, a bleeding time you can do. However, it is not recommended as a screening test as per the ISTH guideline as well as per the BCSH guideline, primarily because there are specific tests that are available. The next comes PFA 100. Now, PFA 100 is a device where you effectively are making the blood flow at a high shear rate through this aperture in the membrane. So this membrane is coated with collagen and ADP or collagen and epinephrine. So you are making the blood flow through it, and if there is a good amount of von Willebrand factor, if the platelet function is okay, this will lead to a closure of the membrane by formation of the platelet plug. So you're basically measuring the capacity of the platelets to form a plug. However, again, this is not very reproducible, has a low sensitivity and specificity, especially if we consider all the defects. For a severe PFD, this is good, but not for a mild PFD. Also, it is not specific for a platelet function disorder because it will again be the closure time will be prolonged in vulnerable disease when the patient has a severe anemia as well as when the platelet counts are low. So normal or marginally abnormal closure times, on the other hand, would rule out a severe inherited platelet function defect, while a markedly prolonged closure time in the absence of anemia, thrombocytopenia, and von Willebrand will suggest a severe inherited platelet function disorder. But it is again a test that is not recommended by the ISTH guideline again because of its low sensitivity and lack of specificity. Now let us look at the results of the first line test. So this 4-year-old boy with epistaxis and melena, when you look at the screening coagulogram, it is completely normal. His platelet counts are normal, and he has microcytic hypochromic anemia. The von Willebrand workup with BWF antigen and resuscitin cofactor activity is also normal. So basically, we haven't really detected anything on the screening coagulogram, and we only know now that the patient has a microcytic hypochromic anemia. Now, the second case was a 13-year-old girl who presented with severe menorrhagia and autosomal dominant type family history. For her, again, screening coagulogram looks normal except for mild thrombocytopenia here, a platelet count of 1,15,000. So at this platelet count, the count does not really explain the increased bleeding that she's having. On the other hand, again, CBC reveals microcytic hypochromic mild thrombocytopenia is there. The platelets, they show some anisocytosis. BWF antigen is low or normal, low normal, I can say that. And the resuscitin cofactor activity, however, is disproportionately reduced. Incidentally, we had the father and the grandmother. I'm sorry for this mistake. So the father's platelet count is also low, marginally low. The grandmother's platelet count is also marginally low. So what does this tell us? That we do have something in the autosomal dominant phenomena. We haven't tested the father and the grandfather for the VWF antigen in the record. So we may still be looking at a von Willebrand disease, maybe the type 2B where there is thrombocytopenia. So what more can the CBC and PS examination offer to us? One part is it helps us rule out pseudo-thrombocytopenia. That is, that if the platelet count is normal, but CBC says it is low. The other part it tells you is what is the platelet type. Another important counter parameter that tells you the same thing is the mean platelet volume. The next component that it tells you is what is the platelet granularity. And the last is abnormalities in the other cells or clues in the other cells. So when it comes to MPV, the small platelets, they are typically associated with Wiskott-Aldrich syndrome. And large platelets are typically associated with Bernard-Soulier as well as with MYH9 related defects, as well as with gray platelet syndrome. So there are multiple causes of large platelets. This also includes the platelet type 1 Willebrand in those disorders. However, the small size platelets, you've got very limited differential. Now, the platelet granularity again is reduced when you're looking at gray platelet syndrome and this syndrome of arthrogryposis with renal dysfunction and cholestasis. What are the abnormalities that we can look at in the other cells? So in the other cells, if we have Howell-Jolly bodies in the red cells, then Storm-Wilkins syndrome is one disorder we can think of. If we have abnormal giant granules in neutrophils and monocytes, celiac acid is something that we should suspect. If we have a lot of dyserythropoiesis, or if we have a lot of RBC and isopoikilocytosis in a young child who's presenting with thrombocytopenia, young male, then GATA1 is a possibility. If we have dole-like intrusions in the neutrophils, then we have MYH9 related disorders, and eosinophilia is seen in ARTC1B related thrombocytopenia. So a CBC and PS examination adds value for your disorders in multiple ways. And it is said that a MPV of over 12.4 centiliters helps differentiate patients with MYH9 related disorders as well as biallelic Bernard-Soulier from those with immune thrombocytopenia. So we typically expect ITP also to show us platelet anisocytosis, and we do see some large platelets. However, this particular size, if MPV is over this, then it is unlikely to be ITP, and we have to think of these disorders associated with large platelets. So how does pseudothrombocytopenia happen? So we have these three images. This image is that of a platelet clump. This image is that of platelet catalytism, and this image is that of multiple large platelets. So if your count is say around 1 lakh, but you have these large platelets, you very well know that the platelet count would be high. However, these patients, some of them, if they are presenting with increased bleeding, they will still need to be further investigated for an inherited platelet function defect. Now, these are the other clues. So in the picture in A, you see a dole-like intrusion, and that is associated with MYH9 related disorder. In the next picture, we have the small platelets. So this is Wiskott-Aldrich syndrome. The third picture, you have platelets. You have a normal platelet with relatively normal granularity, and then you have platelets with absolutely large granules. So we're looking at a gray platelet syndrome. And the picture D is where the granularity appears to be normal, the count appears to be low, but all the platelets seem to be slightly large in size. And this is a patient of Bernard-Soulier syndrome, who was eventually diagnosed as Bernard-Soulier syndrome. In addition to that, the peripheral blood smears have been also used for immunofluorescence. In some of these disorders, they produce characteristic patterns which can be detected. For example, this is an MYH9 related disorder, and you have this large platelet and you have the dole-like inclusion. So this can be detected upon immunofluorescence for the MYH9 protein, which is precipitated in a patient of MYH9 disorder, and you can compare it to the control. In addition, the tubulin 1, the beta tubulin 1 has been used in the TUB1 related thrombocytopenia. Again, you have large platelets. Normally, this protein should have a peripheral distribution on the membrane of the platelet. However, in this TUB1 related thrombocytopenia, the protein diffuses to the center. The next example is that of FLNA-related thrombocytopenia. So this is filamin protein which has been stained. And you can see that in the control, it only limits again to the membrane, while in the patient, you see distribution in the center or abnormal distribution, not just at the membrane, but along with the membrane at the center. For the Wiskott-Aldrich syndrome also, they have described the tubulin abnormality only, so the beta tubulin 1. Instead of being a completely round circle, there are defects like clefting, or there can be even figure of 8 appearances that are produced. Immunofluorescence can also be applied to the diagnosis of PSS, but again, this is not a widely applied test. So what is the next widely applied test? That is evaluation of platelet function. For that, we use the light transmittance aggregometry. Some centers which have the LUMI aggregometry instrument available, that's also a good equipment, because it not just assesses the platelet aggregation part or the increase in transmittance upon platelet aggregation, it also assesses for granule release, the content release. So the dense granules release ATP, and that can be measured. And if they give some signs, then we can also proceed for platelet flow cytometry for the surface glycoproteins. So when we talk about the light transmittance aggregometry, we do the light transmittance aggregometry on the platelet-rich plasma. It is still considered as a gold standard test for the diagnosis of PFTs. And what are we looking for? We're looking for basically abnormal aggregation patterns in response to various agonists. So if we have an abnormal aggregation with 2 or more than 2 agonists, then we have a high odds ratio for a diagnosis of PFT. Coupling it with the assessment of lumination or LUMI aggregometry, that adds value, as I said. The whole blood aggregometry circumvents the high sample volume requirement of light transmittance aggregometry, but is not very well standardized and is not recommended as a frontline test for platelet function disorder. And the LTA has a highest utility when we already have a diagnostic, or when we can establish a diagnostic pattern. A normal aggregation will definitely exclude a severe bleeding disorder, and the number of agonists will matter. There is, however, a challenge with respect to a small child where it is difficult to collect, say, 20 ml of sample that is required. It is also a challenge when your platelet counts are below 1 lakh or below 80,000. And there is a problem with respect to standardization with respect to the agonist and the concentration group. And any abnormality that we find on LTA should always be confirmed on a repeat sample, so that we know that what we are labeling a patient as for life is truly correct or not. So the test is done on 3.2% sodium citrate in 9:1 dilution. Patient preparation is important. Abstinence from alcohol, smoking, NSAIDs, which can affect the test, that is important. Sample collection is preferably at the site, or if it has to be transported, it should be transported at room temperature, not via pneumatic chute. PRP should be prepared within an hour of sample collection, let it rest for 30 minutes, and then complete the testing within 4 hours. Usually, a low centrifugation speed is used, and adjustment is not required when the PRP platelet counts are between almost not just 150, actually 100 to 600 into 10 to the power 9 per liter. So we don't require adjustment of platelet counts, and if we have to adjust when the counts are higher than 600 or when the PRP count is less than 100 or 150, then the control PRP may have to be adjusted. It is better to not use the patient's PPP alone, and at this time, adjusting with physiological saline is better. Now, setting of the instrument needs to be done with PRP to set the limit of 0% transmittance, and PPP to set the limit for 100% transmittance and 100% maximal aggregation. Remember that you do require to see whether your agonists are working okay or not. So there is an unrelated control which has to be tested on the same day as the patient. So this is the guidelines and the initial recommendations for pre-analytical variables. If you have a look, there are slight differences between the guidelines also. So here you have stoppage of NSAIDs or any medication or dietary things. 14 days before, here it is 10 days before. BGH guidelines haven't recommended anything on that part. Blood collection is fairly constant, and all three guidelines are on this page. For transportation, again, to be carried at room temperature. ISDH doesn't mention transportation, this is at room temperature. Then for storage, for preparation of PRP, again, you can see that CLSI guideline would recommend a lower speed for a higher time, 170 G for 15 minutes versus 200 G for 10 minutes. And for BGH, they say either PRP, either methodology is okay. PPP, again, every guideline is on the same page. For assessment of PRP quality, CLSI recommends adjustment at above 4 lakh. However, ISTH doesn't give a specific guidance. BJH guideline clearly states that from 100 to 600 into 10 to the power 9 per liters, there is no adjustment requirement with this. And if it has to be adjusted, it should be done with saline. So these are the recommendations for the pre-analytic variables. For the analytic variables, I have not listed the BJH guidelines because the guidelines are the same as the ones given here. So the testing is done at 37 degrees centigrade. You require a normal subject, as I've already stated, and stirring has to be there in the sample when we are testing. So monitoring time, again, you should ideally do it for 10 minutes. But if you achieve maximal aggregation, say routinely at 5 minutes, then you can run it for 5 minutes also. However, the testing should be completed within 4 hours of sampling. And these are the recommended agonists for LTA as per the BJH guidelines. So this is a component of 8 agonists which can be used. So it is ADP, arachidonic acid, collagen, epinephrine, risto, a thromboxane receptor A2 analog, which is T46619. TRAP, they have not recommended on the first line, and the sample volume would be 7 to 12 ml. So the full panel will include both these agonists as well. For the minimum panel, when you have a small child or when it is you want to exclude a severe disorder alone, then at least ADP, arachidonic acid, collagen, epinephrine, and ristocetin at 2 concentrations should be done. So why do we do ristocetin at 2 concentrations? We'll just see. So let us go back to the case 1. These are the aggregation graphs from the case 1. So this is a flat line with the ADP, a slight aggregation with arachidonic acid, another near flat line with epinephrine, and with ristocetin, you have an initial agglutination and then a disaggregation pattern is there. With ristocetin, you're trying to simulate the adhesion between platelets and von Willebrand factor. So it starts as agglutination, but eventually converts to aggregation because when platelets come together, they do aggregate, right? They aggregate and then they'll release their contents. So here with this particular graph, you see that the initial agglutination happens, but the aggregation and the release of granules from platelets was possibly still defective because they did not aggregate very well. So the diagnosis that was suspected here was Glanzmann thrombocythemia. And what can we do next for this patient? We can assess the glycoproteins by flow cytometry. Typically, what we assess for are CD41-61 for Glanzmann, CD42A and 42B for Bernard-Soulier syndrome. Glycoprotein 6 can also be assessed for the collagen binding, and this is again a disorder which we can diagnose. So let us look at the platelet glycoprotein graph for this patient. So you see here that these cells are your platelets which are binding 42A and 42B, and they are not binding 41 and 61 at all, which means that our suspicion of Glanzmann thrombocythemia is confirmed and there is no antigenic expression of these 41-61 proteins here. So we have the diagnosis for case 1. It is Glanzmann thrombocythemia type 1. Now let us look at one more patient. So this particular patient came to us with epistaxis, gum bleeding and ecchymotic patches, and she was pregnant at that time when she was evaluated. So when you see REPA with arachidonic acid, with epinephrine, there is a flat line for everything. However, here you see an aggregation, aggregation only with ristocetin, which is reduced. With all the other 3 agonists, it is a flat line. So this again, we suspected Glanzmann thrombocythemia, but we got a flow where we had a normal expression for 41 and 61 both. Now that indicated that we have a normal presence of the protein, but the protein is not working. So this is where the diagnosis was put as Glanzmann thrombocythemia type 2. Now this is another patient. This is a 17-year-old girl who presented with menorrhagia. And here you can see that with ADP it is reduced, with epinephrine it is reduced, with arachidonic it is reduced, but with REPA it is not. Now here the platelet count of this patient was about, of the PRP was about 80,000. So we had to adjust the control also. So the reduced aggregation responses to every other agonist were expected because we were running a PRP which was not up to the mark with respect to the platelet count. However, with ristocetin, it was a flat one. So with that, we suspected that we are possibly dealing with Bernard-Soulier syndrome. And the next part is to differentiate it from von Willebrand's disease. So a REPA was repeated here by mixing with the normal control, sorry, the normal pool plasma, which is the PP, which contains von Willebrand factor as a source. So even with that, the response to ristusettin did not correct, which indicated that the defect is in the platelets, it is not in the plasma. So not a defect of von Willebrand factor, but a defect of the platelets. We suspected Bernard-Soulier syndrome here, and when you look at the 4161 pattern, you have the normal platelets here, and they don't express the 42A and 42B protein. So we could diagnose this patient as Bernard-Soulier syndrome. Now, this is a patient who is a type 3 von Willebrand, and you can see here again that the response with ristusettin is absent at the high dose. And mixing with 4 parts of patient PRP and 1 part of the control normal pool plasma PPP can help you distinguish it. And here you can see that with low dose ristusettin, you don't get any aggregation as you would expect. With high dose, this is green line represents the control. There is good aggregation. And upon testing the same plasma as the previous graph that I showed you, where it was a flat line, when we do the 4-in-1 mix, it corrects. So the defect here we know is in the plasma, and the defect is von Willebrand's factor. Now, this low-dose ristusettin is helpful because in the platelet type von Willebrand disease, as well as in type 2B von Willebrand, even with a low dose of ristusettin, where we should not expect any aggregation, there will be aggregation. So low-dose ristusettin is considered up to 0.6 milligram per ml, and high dose is anything over 1 milligram per ml. Now, this is another patient where you have this pattern where you have ristusettin with low dose expected normal response of no aggregation. Response with epinephrine is reduced. It was again repeated. If you look at the graph number 5, it was again reduced. With ADP, there is the initial aggregation followed by some disaggregation, repeat aggregation and disaggregation. Then again, ristusettin here is showing slightly reduced response. So in this patient, we suspected this as a platelet function defect, possibly a storage pool defect, and the electron microscopy studies are underway. Now we resolved our case 1, but we don't have an answer for case 2. So going back to case 2, these were the light transmission aggregometry reports, and this I picked up from BJH. So when you look at the aggregation responses, they look fairly normal to all of the agonists concerned. So what should we do for case 2? So the only thing we can exclude is type 2B von Willebrand, because remember the patient's father, the patient's grandmother, all 3 were affected and all 3 had low platelet count. So maybe we had type 2B von Willebrand, but there is no aggregation response to ristusettin. So it is unlikely that it is type 2B von Willebrand, and it is unlikely that this is platelet type von Willebrand disease also. So if we compile the specific test that we've done till now, for the first case, our diagnosis is clear that this is glandular thrombocythemia type 1 because aggregation responses were abnormal with all of the agonists except an initial agglutination followed by disaggregation response that we observed for ristusettin. And the platelet surface glycoproteins were absent, which confirms this as GT type 1. Now, for the second girl, we had a low normal von Willebrand factor antigen. However, RICOF was disproportionately lower. The ratio was about 0.5, less than 0.5 rather. And the patient was suspected as type 2. We don't have any aggregation abnormalities, and we've already discussed that this it excludes type 2B von Willebrand and platelet type von Willebrand. However, maybe we have a type 2A or type 2B. The unexplained part is the thrombocytopenia, and we have a history of MDS in the father, which can either be a red herring or which can indicate towards a heritable platelet disorder with predisposition to leukemia. Now, this is what we do. So if we get an aggregation pattern that is normal, we can rule out a severe platelet function defect. However, if there is an abnormality only with ristusettin for the platelet function defects, maybe BSS, otherwise von Willebrand also is a differential. With all agonists, if it is abnormal except ristusettin, then we're looking at Langerhans thrombocythemia. If we don't have a defect with, if we don't have a second wave in ADP, and the second wave, the primary and secondary wave, they are only seen with weak agonists, and that too with low concentrations of weak agonists. So that is primary wave is seen with ADP epinephrine. And usually the second, the strong agonists like arachidonic acid or thrombin, they will lead to only a single wave of aggregation. So if you increase the ADP concentration strength from 5 to 10 micromole or higher, then in that case, you will not see secondary waves even normally. So all these abnormalities can indicate a storage pool defect. And if we have a consistent abnormality that is demonstrated on 2 occasions with 2 agonists or more, then we are dealing with possibly a platelet dysfunction, and we will have to effectively diagnose it if it is not fitting into either of these 3 boxes. So again, what is the next step? The next step is we can use Lumi aggregometry to find out if there is a secretion defect or not. So this works on the luciferin-luciferase reaction principle. So platelet activation will release ATP and ADP. So ATP will combine with D-luciferin. Luciferase will break this to produce luciferin adenylate that will react with oxygen to produce light, and we can measure the amount of light produced according to what the standards are given. And it is not the most sensitive test for dense granule deficiency, but again, this is something which can be routinely applied. So these are the graphs that can be obtained. So these tracings on the top, they are the aggregation tracings which we've already seen. And simultaneously, you can monitor the amount of light released with each agonist. And here you see that there is a slight delay in the ATP release with epinephrine. And on the curve here, you can see that the ATP release with arachidonic acid and with the thromboxane analog are completely absent. Now, the other investigation that we can do for dense granules is to do a whole mount transmission electron microscopy. We collect the sample in ACD or sodium citrate. The PRP is prepared and the samples are prepared on the same day of collection. So dense granules, they appear as these black granules, which are black because they are rich in calcium and phosphate. In a dense granule defect, you will see that these granules, they are markedly reduced, and each lab will have to specify their own reference range and calculate their own reference range. Now, this is again a test which can be done, but is not very widely available to most of us who are doing the platelet function testing as well. Now, this one is the same section transmission electron microscopy, and this is used for diagnosis of alpha granule defect. So here, this is the normal platelets where you have the B is a normal platelet where you nicely have these gray alpha granules sitting here, and these are completely absent in this patient. And here was the CBC clue that we had seen earlier also, the lack of granules in the platelets comparing it to a normal individual. So this is again, the electron microscopy can aid us in picking up a reduction in the alpha granules and also of the dense granules. So if we have a look at this, then for the P10 mount, the whole mount that we do, that is primarily for dense granule defect. And the thin sections, they are primarily for the alpha granule defects. And again, remember that the dense granule deficiency is not diagnostic of a single defect. So dense granule deficiency can occur in multiple disorders such as Hermansky-Pudlak and Shediac also. Similarly, alpha granule defects can be again in multiple disorders such as the gray platelet syndrome, the Cleveland related thrombocytopenia, etc. So what is the likelihood if we are doing these two tests? Again, if our light transmission aggregometry shows abnormal findings with two or more agonists, we are very likely to have a platelet function defect at our hands. If we have and understand here that with PPP adjustment, it is not as good as adjustment using only the native PRP without adjusting the platelet count. So if we don't do platelet count adjustments, we actually get better results. For dense granule ATP released by luminescence, the odds ratio is lower. However, if we do a whole mount TEM, then we can pick up the dense granule deficiency far better. And again, remember here that the testing has been done on 2 occasions. Now, what else can we do? We can also evaluate for platelet aggregation on flow cytometry. Again, whole blood samples are possible, and this testing is possible even if you have significant thrombocytopenia. Again, various agonists can be used. For example, ADP, TRAP6, collagen, the cross-linked collagen-related peptide, the arachidonic acid, ristocetin, and the thromboxane analog. What we can detect is using antibodies that only detect the glycoprotein 2B3A, the conformational change that happens upon its activation. For example, PAC1 will not bind to resting platelets, but will bind to activated platelets. Then for the dense granule release, for alpha granule release, the P-selectin, and for dense granule release, the CD63 expression on the outer membrane can be monitored. For dense granule, we can also do the mepacrene uptake and release, and the platelets will be incubated with mepacrene, and we can measure the mepacrene release and test for concomitant for P-selectin. So here is an example where we have the PAC1 binding. So convulsion has been used, and this was Lutfi's paper. She has shown that gating upon these platelets, upon stimulation with convulsion also, you should have had a peak here if it was normal. However, the PAC1 is completely absent, which means that the GP2B3A was not activated here. Now, this is again convulsion stimulated platelets which are failing to express CD63, and this is a patient with delta granule disorder, and you have a complete absence of CD63, which should have expressed if the dense granules were normal. So now let's see what we now have with all the testing that we've done. For patient 1, we have a clear diagnosis. For patient 2, We have a possibility of one variant type 2A or type 2M. However, haven't yet explained the familial thrombocytopenia, and we haven't explained the history of MDS, whether it is a red herring or whether we need further evaluation. So what should we do for this? Now, therein comes the role of genetic testing. So for genetic testing, we can confirm the diagnosis suggested by the screening tests. We can also identify the diagnosis when the result of the initial screening, they are indicative but not clearly informative. What can we use? We can use the standard sequencing when we have a clear diagnosis. For example, if I know my case 1 is a GT, then I can specifically target 2 genes using standard sequencing. Or if I have a family member who requires evaluation and I know the patient's primary diagnosis, then I can evaluate the family member correctly. It is good for monogenic disorders, but not when we don't have, not when we don't really know, or we have a very broad list of differentials with. For that, it is targeted resequencing of a panel of genes which can be commonly applied. Now, this is good for sequence variants and for small insertions or deletions, but will miss deep intronic variants as well as copy number variations in these genes. The next approach is whole exome or whole genome sequencing. So high throughput sequencing, as I said, has led to a very, very high rate of discovery of variants in platelet function disorders. So herein you have a list of whole exome sequencing, which has contributed over 20 variants. And now this is data of 2018. And in the last 4 years, even more genes have been added to that list. This is one way that high throughput sequencing has helped. So how do we proceed ahead? So when we have a specific phenotype, a known family variant, then we can do a targeted family screening. If we have a familial variant that is unknown, we can test for single gene. And if there is the gene defect which manifests in an autosomal dominant form, then we know that we have a diagnosis. If it is in homozygous or compound heterozygous form in a recessive disorder, then again we have a diagnosis. The challenge comes in when we have variants of uncertain significance. So when we know that we have a variant, but we don't know what impact does it have, or when the sequencing results they come out to be negative, then we have to look at alternative strategies for testing. If we have a non-specific phenotype, but we have a confirmation of thrombocytopenia, or when we have shown that there are definite platelet dysfunction abnormalities, then we can go for the targeted NGS-based gene panels. Again, classify them. Challenges are always with variants of uncertain significance and how to classify these patients, whether these patients do have the disorder, whether they don't have the disorder. That is some part which we don't know at that point in time. However, if we have a patient who has a platelet function defect, which we have seen or has thrombocytopenia, but also has multiple other manifestations where we don't know what we are dealing with, then the good approach is whole exome or whole genome sequencing. Now, this is from a paper from Blood where they screened around 2,396 patients using the thrombogenomics panels. So this has two versions, and when you look at this, it has multiple genes affecting coagulation, thrombosis, as well as platelets, and this was applied. So the interesting part that they came up with was that in all of their patients, if you look at all the patients, they had a yield of only about 40%. For platelet count disorders, that is heritable thrombocytopenias, the yield was about 50%. Platelet function disorders, low yield again 25%. However, where the bleeding was unexplained, where there were no phenotypic manifestations or no platelet or no distinct abnormalities on the platelet test, there the recovery was only 3.2%. Now that indicates that genetic testing today cannot replace the testing for everything. Recovery is for, as I said, for 50% of heritable thrombocytopenias, 25% for inherited platelet function disorders. So basically, if you have a well-characterized individual where you've done the phenotypic testing, therein applying NGS will be able to diagnose your patient correctly and the recovery will be high. However, for many patients, even with the current panels, the defect will remain unknown. And of course, this data will change and will evolve as there is a higher number of genes which is added to all these panels. And these panels, they are evolving and there are efforts to sort of keep on updating this list. Also, to remove the variant of uncertain significance, if all of us, we submit our data to the ClinGen database, which ISCH is heading, then they twice a year report their data in bulk to ClinVar, where the variant of uncertain significance, which has been, say, reported by 4 people in 4 different families, will no longer remain a variant of uncertain significance. It will be very likely turn into a likely pathogenic or a pathogenic variant. So coming back to our case, our type 2, so there was a heterozygous mutation in the von Willebrand factor. This was considered to be pathogenic, previously has been reported with type 2A. But the story did not stop there. Because this was a targeted resequencing that was done, the RUNX1 gene was also included in the panel. There was a heterozygous mutation in the RUNX1 gene. The RUNX1 gene is the familial platelet disorder. It is a germline predisposition to AML and MDS, and there was a history of MDS in the patient's father. Now, this is a heterozygous mutation resulting in a breakage or a termination mutation in the RUNX1 protein. This is again pathogenic, has been previously reported in a patient of MDS which developed at the age of 50, which means that there are two diseases here. There is one relevant disease, possibly type 2A, but there is also the RUNX1 mutation, which explains the thrombocytopenia. When we look at the specific tests, for first one, the first patient was a GT type 1. The family, they wanted to go ahead and have more children. So the genetic sequencing was done, specifically Sanger sequencing for ITGA type 2B. And there was a mutation that was detected in the homozygous state. And this was again determined as likely pathogenic. The parents were heterozygous and they were counseled for future pregnancies. For the 13-year-old girl, we had these two mutations that we just discussed. So basically, this is VWD type 2 ANM along with a familial platelet disorder or a RUNX1 mutated platelet disorder. Now, herein comes the role of informed consent. Whenever we are doing genetic testing, we need to take consent from the individual that they are ready to or they're willing to undergo the genetic testing, because many of the genes that we detect, for example, the RUNX1 mutation, the patient with this RUNX1 mutation, there is no intervention per se, but the patient will require follow-up for the rest of her life to determine her risk for MDS or AML. And genetic counseling is an important part. So these two things we cannot forget, and it is ethically incorrect if these two are not offered to our patients in whom we are doing genetic testing. So challenges with high throughput sequencing, even though the cost has come down, the cost for our Indian patients does remain a problem. With respect to reporting of variants, having variants of uncertain significance becomes a challenge because we have the disease manifestation in the patient. We expected the HDS to answer everything, and we've landed up with a variant of uncertain significance. So all of us have to familiarize ourselves with the American College of Medical Genetics guidelines and to identify which variant is pathogenic or not. The copy number variant reporting is yet to be incorporated for many guidelines, so that again can become problematic. Databases are lacking. The efforts are underway with respect to the thrombogenomic panel as well as to the ISTH-led stringent platelet disorders expert panel. And we have to remember the ethical issues for consent and for genetic counseling after obtaining the results. So this is again a resource from ISTH subcommittee on genomics and thrombosis in hemostasis. So they have this list of gold variants which they keep updating, and this is freely available to everybody to have a look at if in case they are designing a panel for their patients suspected to have inherited platelet disorders. Now to summarize, inherited platelet function disorders include heritable thrombocytopenias as well as platelet function disorders. All of these, they do cause a mucocutaneous type of bleeding rather than a deep joint or tissue bleed. First line testing includes seeing whether the bleeding history is significant or not by doing an ISTH path, then a screening coagulogram, CBC, a review of the platelet morphology and counts, and also remember these syndromic features that these patients will have. Bleeding time and PFA 100, they're good for a severe inherited platelet function disorder, but not as a standalone screening test. For that, specific testing by light transmittance aggregometry by platelet surface glycoprotein assessment, and if you can add it, Lumi aggregometry is good. Now, the further tests here will be guided by the results of the initial test. You can do the platelet function testing by flow cytometry. You can do high throughput sequencing, electron microscopy if it's required. And for variants which are especially with ETB6, RUNX1, NCAR2, D26, which basically give the patient a risk for malignancy, the concept of genetic counseling and consent has to be specially looked at. Now, this is an algorithm which basically summarizes everything that I just said today. And with that, we come to the quiz. So with the quiz, the first question is, what is not a common kind of bleeding associated with platelet type of bleeding? You can type your answers in the chat box. Option A is skin bleeds, including ecchymosis and petechiae. B, deep muscle bleeds like psoas muscle bleed. C, menorrhagia. D, epistaxis. You can type your answers in the chat box. Okay, so most of you are answering B, which is indeed the correct answer. So deep muscle bleeds are not characteristic of a platelet type of bleeding. It is characteristic of a coagulation factor type of deficiency. Now here you have to identify the diagnosis based on the peripheral smears shown. Your options are a gray platelet syndrome, Bernard-Soulier syndrome, platelet type 1 Willebrand disease, or MYH9 related disorder. So again, I think I have a very learned group of audience today. They've nearly all of them have identified this correctly. And the correct answer is the MYH9 related disorder. What you see here is a dole-like inclusion, and you have the large platelets along with thrombocytopenia. Now, question number 3 is, what does light transmittance aggregometry assess? Does it assess the secretion of ATP by platelets upon activation by adding agonists? Does it assess increased transmittance of solution after platelets aggregate upon exposure to various agonists along with the ATP measurement? Does it assess increased transmittance of solution after platelet aggregate upon exposure to agonists? Or does it measure increased absorbance of solution after platelets aggregate on exposure to various agonists? So the correct answer here, as expected, is C. You're only measuring the transmittance of the solution, because when your platelets will aggregate, they'll sort of try to settle down. So the turbid solution would become less turbid and more light will be able to pass. So that is the only thing we are measuring. We're not measuring the ATP release at all in light transmittance aggregometry. So correct answer is C. Now this is the fourth question. What do you think is the diagnosis, and what is the further investigation that you would like to do? So you have a list of diagnosis and a list of the further investigation. Okay. So I think I only see one answer, or two answers. Okay, A. So I think all of you are nearly getting it right. So this is Ganson thrombocythemia. This is the case that I showed you during the presentation also, a disaggregation with ristocetin, a reduced on an acid aggregation with all other agonists, and you can simply do a platelet glycoprotein analysis to confirm your suspicion. So this is the correct answer. And the last question in the quiz is, what is not true for high throughput sequencing in the diagnosis of inherited platelet function disorder? The first is, it is ready to replace the phenotypic evaluation of platelets or all other platelet function testing. The second option is, you can detect it using a targeted resequencing of selected panel of genes, or you can do whole exome or whole genome sequencing. Third is, you have to confirm a discovered mutation by standard sequencing. D is, its recovery is low in patients with uncharacterized bleeding. So again, I see responses which range from B, C to A. So this is the part where most of us are a little confused. So it is actually, the correct answer is C. At the present time, it is not ready to replace the phenotypic evaluation of platelets, because in the data that I showed you, clearly patients who don't have a well characterized or won't have a definite bleeding disorder indicated by phenotypic testing, the recovery is low. Even where you have a phenotypic presence of a defect, there also a recovery is only 50% for hereditary thrombocytopenias, and it is around 25% for a platelet function defect. Now with that, I'll stop, and I'm very happy to take questions. And I would like to acknowledge and thank SHPT and Dr. Maitri for inviting me here to talk about the topic. My teachers, Professor Saxena, Mr. Suresh and Mr. Datta, who are the lab technicians and AIMS who have done all the work. Dr. Nair, Dr. Jasmina Aluwalia for all the inputs I've always got from them. Dr. Ganesh, my colleague here, my HOD, Professor Mahakasa, as well as all the DM residents. So I'm happy to take questions. So I have a question which says I should explain the 4:1 mixing. So 4:1 mixing is done by taking 4 parts of the patient's PRP that is there, adding 1 part of the pool normal plasma, platelet poor pool normal plasma. Why are we using a 4:1 ratio? Because if we try to do a 1:1 mix, then we dilute out our platelets to a large degree. So a 4:1 mix will correct, say it has a 100% value, the normal pool plasma has 100% vulnerability factor. If we do a 4:1 mix, we get to a value of about 20%. At a 20% normal functional von Willebrand protein, it will definitely not lead to a defect in the ristocetin. So it will correct. We'll be able to differentiate Bernard-Soulier syndrome from von Willebrand's factor. So in a Bernard-Soulier syndrome, there will be no correction, because if it is in a Bernard-Soulier syndrome, it is a defect in the platelets. So adding normal pool plasma will not help. However, in a patient of von Willebrand's disease, there will be correction with that. So the next question is, can I repeat the LTA graph interpretations? Okay, so let me go back to the relevant slide. So I'll share my screen again. Okay, in the meanwhile, while I sort the screen share out, the question that I have is, are we doing von Willebrand factor antigen on fully automated coagulameter or by ELISA? So right now we are using the fully automated coagulameter to do our von Willebrand factor antigen, and most of the fully automated coagulameters will have the immunoturbidimetry method to give you the report for the von Willebrand factor antigen. However, if you don't have a fully automated coagulameter, there are occasional semi-automated coagulameters that do have that capability. In addition, you can easily do it on the ELISA with respect to the antigen level. So this is case one. When we look at the aggregation graph, here in look at this, the 10% is minus 10 is here, 0 is here, and we have the 90 here. So it is an increase in the transmittance that has to be measured. So initially, whenever we start with, we'll get the starting point is here, and as the time will progress, the platelets will aggregate and the transmittance will increase, and this will be measured here. So in the case one here, we see that the number one is this graph. The number one graph is that of ADP, and it is a flat line. Number two is arachidonic acid, and this is number two, the green one. And you can see that the aggregation is there and it is reduced. The third is epinephrine, and herein is the third number. And you can clearly see that it has sort of failed. There is a failure to start aggregation also with epinephrine. And the fourth is vitrocetin, and this is the normal dose vitrocetin. So you have or the high dose vitrocetin, and you have the initial aggregation that has happened. So there is an increase in the transmittance. So this is the initial agglutination. However, the agglutination, after agglutination, the platelets will come together and they will eventually release their content. So herein, if the aggregation had happened normally, you would not see this reduction or this disaggregation pattern, and it would have continued as a trend. So this pattern of defective aggregation with all agonists except vitrocetin is classically suggestive of Glanzmann thrombopenia. It can also be seen in another defect, which is the LAD type 3, but your patient's profile will obviously be different. In a LAD type 3 patient, you will also have a history of frequent infection. So that will point towards the diagnosis of LAD type 3. Now going on to the next graphs. So herein we have a case of Bernard-Toulier syndrome where you have reduced aggregation with so sorry, I think yeah. So this is the second patient. Again, this aggregation with vitrocetin is there, but it appears to be reduced. There is aggregation followed by a slight disaggregation here as well. With all three other agonists, it is absent. So again, we are looking at the patient of GT. Now, the next particular graph is there where we have aggregation. Again, one is ADP. It is there, but it is reduced. Again, with two, it is there, but it is reduced. With three, that is arachidonic acid, it is there, but it is reduced. And this sort of a pattern, we know the PRP of the patient. So if the PRP count of the patient is less than 1 lakh, we will get reduced aggregation responses. However, unlike the reduced aggregation responses with vitrocetin, there is a complete flatline. And with that flatlining, we know that the defect is primarily in the vitrocetin-induced aggregation, and we do the 4:1 mix, which I just explained to differentiate the same. And we can confirm it using the glycoprotein analysis as well. So with that, I will stop sharing the graph for the platelet aggregation. Now, the next question that I've got is any specific molecular diagnostic test for platelet function except whole exome and whole genome sequencing. So I did show you results of a targeted resequencing panel. For platelet function defect, for example, if I have a patient of Glanzmann's where I'm suspecting Glanzmann's thrombopenia, then I can just do Sanger sequencing of the two target genes to identify the defect. And that is more so for guiding the prenatal diagnosis for the further kids rather than in that to diagnose that case first. Now, the other question that I have from Dr. Amia is whether is it possible to perform aggregometry in a patient with a platelet count of about 40 to 50,000. It is very, very unlikely that you'll be able to do a light transmission aggregometry in this patient. That is because when once you start preparing the PRP also, your count is unlikely to rise above 70 or 80,000. With that caveat, you can still attempt aggregometry by adjusting the control PRP count also to that value. And at this point, we need to understand that very likely we will have a non-diagnostic test and we may have to repeat it when the platelet counts become better. Now, the next question that I have is, do all von Willebrand disease require PFT? Obviously, they don't. if you are doing VWF antigen in your first line testing and you have a value that is less than 3%, you have a clear cut diagnosis of a type 1 vulnerability with you. If you've done a recop and an antigen and if you have both reduced proportionately, then you have a diagnosis of type 1. And if you have disproportionate reduction in the risk-to-certain cofactor activity or the GP1BR or 1BM axis, and your ratio of the antigen, the ratio of the functional to the antigenic test is less than 0.7, you know that you have a type 2 vulnerability. However, where does platelet function testing help? Platelet function testing helps because initially you don't know whether you're dealing with vulnerabilities or PSS. You haven't done VWF antigen in the first. There it helps you pick up the type C and the severe type 1 defect. In addition to that, the low dose ristocetin is critical because aggregation to low dose ristocetin, anything less than 0.6 milligram per ml, if there is aggregation, then you know that you have a response or you have a gain of function mutation somewhere. So either the gain of function mutation is in vulnerabilities where the VWF is binding excessively to the platelets, or you have a mutation in the platelet where they are binding excessively to the vulnerability factor. So for that, we require a PFT. Now, the next question is, what should we mix to bring the platelet count to normal range? So if our PRP platelet count is say over 6 lakh, then I would use physiological saline, that is the standard normal saline, to bring it down to the reference, to bring it down to less than 6 lakh. Why would I do that? Because when we centrifuge at high speed, we do release some inhibitors of platelet aggregation. So the patient's native PPP will contain those inhibitors, and we don't want them to introduce a variable with respect to interpretation of the aggregation. So I've got an interesting question. How common is PRAC channelopathy with STIM1 mutation? So with STIM1 mutation, they've got two diseases, the Stolmokin syndrome and the York syndrome. York syndrome is relatively rarer. Stolmokin is relatively common, but the word is relative. Overall, these disorders are rare. And the next question is, I think, directed at the host and not to me, whether they can get a recording of the presentation or not. Okay. So with respect to recording of the panel, I think the recordings are available on the ISHBT website. And if there are no more questions, I would like to thank all the attendees who stayed back and listened to the lecture here today. Thank you so much. And I would end by again thanking the ISHBT team for having asked me to deliver this masterclass.
Thank you very much. Thank you.